my dear friend, Dr. Rajendran, President, and Dr. Singaravelu and Thirumurugan, and all the officials of IAP, and also my close friend, Dr. Jalil and Nandini Kumaran, who told me in Pedicon that I have to give some session for the vaccinology for Tamil Nadu IAP. So I thought, why not start with the vaccine which is given in the newborn period? And I thought I will discuss something about BCG vaccine. I mean, at the outset, I admit that though I have a lot of interest in vaccinology, unfortunately, I have not had much experience personally with vaccine research related to TB vaccine. And since there is hardly any significant research going on at the moment, I have not had any opportunity. So whatever I am sharing with you is only from literature and from history. With this caveat, let me start the session by telling you that what are all the areas that I'm going to cover. The history of this vaccine is very, very important for us to learn. Most importantly, since this is a group of pediatric practitioners from Tamil Nadu and neighboring states, I thought we will revisit areas related to BCG vaccination practice essential. And we will also discuss something about the efficacy of the BCG vaccine, a very controversial area, and the limitations of BCG vaccine. And a new concept of BCG revaccination is doing the rounds. Let's have a look at it. And I would end with a review of the very brief review of new TB vaccines coming in the pipeline with a futuristic view and summary. If you look at the history of BCG vaccine, the story is very, very interesting in the sense it has seen lots of obstacles. The story of the BCG vaccine will tell you there have been so many obstacles for the same. In fact, 1902, Mycobacterium bovis was identified and it was sent to Institute of Pasteur. And mind you, they passed it through 239 ox bile medium contents, and they attenuated the Mycobacterium bovis. And then three scientists, Nocard, Calmet, and Calmet-Guerin, came together. They were all disciples of Pasteur. They came out with the BCG vaccine. We all know Koch discovered BCG vaccine. And the BCG vaccine was first applied in 1921. It went into a disaster, Lübeck disaster, with contamination, a lot of human deaths, and a lot of hue and cry. In 1993, the WHO declared the TB as a global emergency. And 4 strains of the BCG vaccine were administered in 2000. And from 2000 onwards, you've been reading a lot about non-specific effect of BCG related to immunity in human beings. And in the 2004, the WHO came out with a statement that all healthy neonates in high burden settings should be vaccinated. That's how the story evolved. In 2021, they celebrated the 100th anniversary. So it has been there for 100 years, time. I mean, it has stood the test of time and it has not been replaced. So that's history for you. Coming to the BCG vaccination, which is given mostly in the newborn period, I'm sure very few in the audience would have given BCG vaccine. Most of the BCG vaccines that are given in Tamil Nadu are in public health settings, and most of them are given by public health nurses. But few like me in clinics, I do give BCG vaccine in my clinic, though there is a lot of practical difficulty in giving the same. Before we go into vaccination, the first thing is to differentiate 2 types of BCG vaccine. The reason why I'm putting this up is that, there is a lot of use with the explosion of cancers in adults. So much of BCG, Onco-BCG is being used in adult medicine. And mind you, the manufacturers are same. Both Onco-BCG as well as our Tubervac, our BCG are being manufactured and supplied by Serum Institute. If you are to order BCG vaccine, please be careful. You should not end up ordering this green box. This is actually Onco-BCG, which contains much more bacilli than the BCG, which is given for neonates. So one should be careful. That's my first caution to anybody who uses BCG in clinics. I'm going to start with an audience question. Of course, I'm not going to put a poll. I don't have a Google poll or anything like that. If one were to pick up the correct statement regarding the composition of BCG vaccine, there are 4 statements made here. Statement A says BCG vaccine does not contain preservative. Statement B says contains sorbitol as stabilizer. Statement C says it comes in transparent glass bottle or vial. Statement D says the dose is 0.1 ml for all ages. If I'm going to ask you to pick up the correct statement, that means 3 out of these 4 statements are wrong, only 1 statement is right. I am sure everybody will come out with a clear answer. BCG vaccine does not contain any preservative. It doesn't contain any preservative. It contains only the bacilli. This is very unique. Most vaccines contain preservatives or some antibiotic like neomycin. BCG does not contain any preservative, but it contains sorbitol. And, it comes in a dark bottle. Okay. And the dose varies from age to age. I'll come to it later. The BCG vaccine contains freeze-dried vaccine. It's supposed to be called Moscow strain 361I. And 1 ml is the amount that you can prepare with the vial. If you use 0.05 ml, which is the neonatal dose, it will come for 20 doses. If you use 0.1 ml, it will come for 10 doses. And the freeze-dried vaccine is something which is, which is coming in an amber-colored bottle, which is white, and it's crystalline. And it does contain some stabilizer in the form of sodium glutamate. Sodium chloride is the diluent. Mind you, that's very, very important for practitioners to note. In case that ampule which comes along with the BCG is broken, I've seen doctors using distilled water, which is wrong. You should use only normal saline, which comes in the ampule. You should not use distilled water. And it can be stored once it is in a lyophilized form, that is, the powder can be stored for up to 12 months at 2 to 8 degrees in the refrigerator. But if you reconstitute the vaccine with saline, you should store it at 2 to 8 degrees and you should protect it from light. If your clinic has windows, you should not expose it to sunlight. And you cannot use it for more than 4 to 6 hours. Even if you have only 1 patient, you don't get 1 more patient, you can't use it for more than 4 to 6 hours. You have to discard it. Coming to the technique, which is very, very cumbersome. The administration of BCG vaccine is not an easy joke. In fact, I've seen many sisters doing a good job, doctors not doing it. I've given the opportunities for PGs. They don't use the correct technique. If I were to ask you, which is the correct statement regarding technique of BCG vaccination, here I have given you 4 statements, out of which 1 only is correct. A is, if correctly given, causes no wheal. B is, can be given anywhere intradermally. C is, 0.05 ml is the dose irrespective of the age. And D, antiseptic not to be used on the skin at the site of vaccination. But you'll be surprised that the correct statement is that for administering BCG vaccine, unless, unlike administering DPT or any other vaccine, you're not supposed to apply antiseptic on the skin at the site of vaccination. Either you use nothing or you use simple water, or you ideally don't use anything. Skin is sterile. A normal newborn's baby skin is sterile. You're not going to introduce any infection by giving it intradermally. Okay. And if correctly given, it should cause a wheal of about 7 millimeter. And the recommendations for intradermal injection, the site is universal. It should be only in the left deltoid insertion. The dose varies from age. It is 0.05 ml in the newborn, and beyond 1 month is 0.1 ml. And the most important point, please do not apply antiseptic before giving BCG vaccination. The site I already mentioned is the left insertion of deltoid. If properly given, 5 to 7 millimeter wheal should be given. Other anatomic sites, there is no data on the safety and efficacy. But there are quite a few mothers who ask for cosmetic reasons administration BCG in the thigh, gluteal region, elsewhere. It is not recommended. It's not that it's not safe. There is no data on the safety. No studies have been carried out saying that you can give in other areas. So it's better to stick to only left deltoid. Dose I already said, only beyond 1 month it is 0.1 ml. All neonates should get only 0.05 ml. And of course, you should use an insulin syringe with a 27 gauge needle. You can't use the syringes which we use for subcutaneous or intramuscular injections. Most of them will have a needle of 23 or 24 or 25. This is the insulin needle. You must keep ready stock of it if you are giving BCG. And the technique is quite difficult. You should actually stretch the skin between the thumb and the forefinger. And the bevel should be administered at about 15 to 30 degree for about 2 millimeter into the superficial layers of the dermis. But in fact, early days when I used to give BCG, many a time it used to spurt out and it used to come out through the skin to another orifice. You have to be careful. You have to keep the syringe parallel to the skin, nearly parallel to the skin. And you should raise a bleb showing tips of hair follicles. That is a correct technique. And you should insert it at the deltoid insertion into the humerus. And if you use sites other than the insertion of deltoid, there is a higher chance of keloid formation. The higher you give, more are the chances of keloid formation. And higher you give, more are the chances of something like supraclavicular adenopathy developing secondary to BCG vaccine. This is a very nice demonstration of the technique. You see here, there is hardly any gap between the skin and the needle. It is only raised by about 5 or 10 degrees, the syringe. And the injector is getting a nice wheel without any spillover. And he is stretching the skin correctly. This is the correct technique for BCG vaccination. I said earlier, if you have applied spirit, you have to wait for it before it dries off. But don't apply any antiseptic. And one other important technical point. If you have given BCG in the left arm, avoid giving any other injection in that arm. They say it's better not to give any other vaccine for at least 6 months. Of course, fortunately, we have only influenza and typhoid vaccine at 6 months. And none of the vaccines given before we give in the deltoid, even influenza and typhoid, we don't give it in the deltoid. Only MMR, we may give it at deltoid at 9 months. But you must remember, you should not be giving any injection at the BCG site. This holds good for even older children. That's why I put this point. If the injection is too high, too anterior or too posterior, different lymph nodes may get involved. The chances of BCG adenitis are more. What happens when you give BCG? When you give BCG, you must counsel the mother. Anticipatory guidance is required. Otherwise, what will happen? They'll come to you at 4 weeks saying, sir, the whole thing is swollen. Or they'll come at 8 weeks, sir, something is coming out. Discharge is there. So you must tell them the characteristic evolution of the injection sites after BCG. At 3 weeks, what you will see is a small area of redness like this. And at 6 weeks, if you are given correctly, a raised papule with minimal redness will appear. At 10 weeks, there may be a shallow ulcer with crusting. And at 12 weeks, it heals with dry edges. And this is the nice BCG scar after a successful BCG vaccination at the insertion of deltoid. This shows that the BCG vaccination has been done appropriately. If I were to ask you a question regarding a case scenario where this happens frequently in my practice. A mother brings an infant at 6 months saying that there is no BCG scar. Sir, I took the BCG vaccine in such and such a hospital. They said something will happen here. Nothing has happened. No scar has appeared. What do you do? It's a dilemma. Here I have given 4 options. What are the 4 options? First option is do Manto. If it is positive, say 5 or 8 millimeter, oh, BCG has been successful, don't worry. Second, reassure the mother, nothing is needed, go back. Third, revaccinate. 4, a test which was done 30 years back, now it's not available in most labs. Lymphocyte migration inhibition test, perform it very scientifically. What will you do? The correct answer is revaccinate. The current recommendation is that if there is no BCG scar at the site of neonatal BCG vaccination, at 6 months, if there is no scar, you don't do any tests, you straight away give revaccination unless there is a specific contraindication for BCG vaccination. And absence of scar is not uncommon, and it's not a reliable indicator of the failure of the BCG vaccine. If there is failure even after the second vaccination, questions may arise. What do you do? Don't do anything. And Manto test is not required for BCG vaccination in anybody and in any age. You can boldly give BCG without Manto testing. Schedule, it is recommended to be given in the neonatal period. We all know hepatitis B has to be given immediately and BCG has to be given before 6 weeks, preferably before discharge from the hospital. And if it has been missed, along with 6 weeks, other vaccines you can give. Only thing is at 6 weeks means it is 0.1 ml. Beyond 4 weeks, the dose is 0.1 ml. And in the universal program of immunization, BCG vaccination is approved up to 1 year. But the ACVIP says you can give up to 5 years. If you have an NRI child who has not been given BCG, this is a very frequent occurrence in my clinic. Parents come to me, they are worried about tuberculosis. They ask me whether BCG should be given. I always advise them, no need for Manto testing. You can give BCG up to 5 years. I give them. The only thing is, many a time after I gave BCG vaccine, next visit, the parents will say, the American pediatrician criticized, why did you do it? It will cause confusion and TB diagnosis later. I don't think that is right. You should give the protection to Indian children as long as they are going to visit India. Regarding the diluent, it's very peculiar that we use saline as diluent and not distilled water. If I were to ask you what is the reason, very simple. If you use distilled water, it will act as an irritant. You should use only saline. And if you use distilled water, it can cause clogging and necrosis of the skin. Violent reactions can occur. So for administering BCG vaccine, we should use only saline. Sorry. Coming to the administration of BCG newborn, why is there a recommendation that you should give only 0.05 ml below 1 month and 0.1 ml in any age? The reason is the skin of the newborns is thin. If you give 0.1 ml, it may break the skin and the vaccine may reach the deeper tissues. More is the amount delivered to the underlying tissues beyond skin, more is the risk of local abscess and lymphadenitis. So majority of BCG adenitis or BCG abscess is not abnormal immune reaction. They are all due to inappropriate technique of either too much of BCG being given or too deep a vaccination. These are the two reasons which causes a lot of problems like lymphadenitis and abscess. Suppose somebody asks, sir, I have given the BCG subcutaneously. Is there any harm? You must remember, if you give subcutaneously, again, the risk of adenitis and abscess formation are high. There is also an increase in the risk of dissemination if you give beyond the skin, particularly in immunodeficient children. Ideally, you should give only strictly in the intradermal route. The next controversial area is the immunogenicity, efficacy, and effectiveness of BCG. Several factors influence the benefits of BCG from vaccination, which includes post-immune status, post-genetics, the strain of BCG used, previous exposure to mycobacteria from the environment. In India, there is a lot of circulating atypical mycobacteria. They interfere with production of immunity to Mycobacterium tuberculosis. And also the Mycobacterium tuberculosis strain and the level of exposure. The more the exposure, the less are the chances of the vaccine protecting the individual. It also depends on the age of vaccination, distance surprisingly from the equator. That's one of the reasons, in countries like India, it's not very effective. Prior tuberculin sensitivity, positivity, study quality, all factors can affect BCG vaccination. But what has been agreed upon, definitely BCG protects against disseminated TB and CNS TB. There is no doubt at all. There is enough evidence, particularly neonatal BCG. There is enough data from Africa and Asia. It protects against CNS TB, miliary TB, and disseminated TB in young children. But it offers very little protection against fibrocaseous pulmonary TB in older children, adolescents, and adults. Hardly there is any protection. And we all know the Chingleput trial, which came out with data that a 7-year follow-up, 7.5 years follow-up, offered very little protection to adults. And even in children, against cavitary pulmonary tuberculosis in adolescents, it offered very little protection. So that doesn't mean we should discontinue BCG. It continues to protect against CNS TB and severe forms of TB. Protection against pulmonary TB, if given in the neonatal period, during childhood, it's about 59%. And it's higher in settings further away from equator. Randomized controlled trials have shown very high protection against pulmonary TB in developing countries and not in developed countries. Meningeal miliary tuberculosis, unequivocal data is there. There is no controversy at all. If I were to ask you, BCG has got a lot of protection against other infectious diseases other than tuberculosis. What are they? Does it protect against Buruli ulcer, leprosy, serious forms of TB, SARS-CoV-2. There was a lot of talk that BCG vaccination might protect against SARS-CoV-2. The answer is there is enough data now from the West as well as from African countries. BCG does not protect against SARS-CoV-2. It did not reduce the severity also, but it definitely prevents leprosy, definitely prevents serious forms of TB, definitely prevents Buruli ulcer, which is well known in Africa, not in India. And it also protects partially against non-tuberculous mycobacteria causing lymphadenitis. And more importantly, the other effects, immune effects of BCG, they are non-specific. They are not adaptive, they are innate. Studies have shown in Africa, infants given BCG, they suffer less from neonatal sepsis, less from RTI, less from fever when compared to non-vaccinated. This may be because of improvement in trained innate immunity, improving the levels of interferon gamma, IL-1B, and pro-inflammatory cytokines. So BCG might protect against infections in childhood, might also protect against cancers in adulthood. There's a lot of confusing data, but this data from Africa suggests that under 5 mortality itself might have been reduced by BCG. And this diagram shows where all it can act. It can reduce even mortality due to malaria in Africa. It can improve the levels of TNF alpha. It can actually protect against fungal infections. And it is believed that even Staph aureus infections are less severe in those who have received BCG. Let us take up the adverse effects of BCG. Well, it's an essentially safe vaccine. Most of the side effects are local, the commonest being an abscess at the site and an exaggerated injection site reaction, lymphadenopathy, and delayed healing of ulcer. These are the most common the 4 adverse effects. Abscess, you do nothing about it. You don't give any antibiotic. Nothing is required. It's a sterile area. Injection site reaction with ulceration, a little bit of serous discharge, do nothing. Reassure. Lymphadenopathy, most of them resolve by themselves unless there is immunodeficiency. The ulcer may take a longer time. It may heal after 6 months. You do nothing about it. You don't interfere. But if there are serious adverse effects, what are the serious adverse effects? Osteomyelitis. If you happen to give it deep, and even if you give it superficially, BCG vaccine can cause osteitis or osteomyelitis for the humerus. And of course, disseminated BCG infection, what is called BCGiosis, can be fatal. There are some well-defined criteria for diagnosis. These infants, they may develop hepatosplenomegaly with lymphadenopathy, generalized or axillary and cervical or mediastinal. You should identify the BCG by genome sequencing as not human TB, but bovine TB by culture. And dissemination should be evidenced by A or B by the organism. That is a positive blood or bone marrow culture. You should have evidence of infection at 2 or more anatomic sites beyond the region of vaccination. For example, you must have evidence of infection somewhere in the lungs or in the liver, in the spleen, or supraclavicular nodes, etc. And you must have a systemic syndrome compatible with mycobacterial disease, fever, anemia, weight loss, death. I have seen at least 3 cases, all the 3 succumbing. And 2 of them had immunodeficiency. 1 we could not identify, still child died. It's a very serious disease, very difficult to treat. Coming to the contraindications of BCG, the number of contraindications as seen in this slide are so many. But for practitioners, it's very important to take a proper history before deciding to give BCG vaccination. What history should you obtain? You must take antenatal history, whether the mother is immunosuppressed. If she is on TNF-alpha inhibitors for vasculitis or rheumatoid arthritis, you should delay BCG in that infant for 6 months. You must be careful. You should not be giving them. And immunosuppression in the baby, which may be in the form of corticosteroid use like nephrotic syndrome, 2 milligram per kg for more than 1 week, or 1 milligram, more than 1 milligram per kg, more than 2 weeks. You should delay BCG for 3 months. Of course, it's not going to happen in the newborn period. An older child, if the child has not received BCG, you have to keep in mind steroid therapy. And any suspicion of SCID, lymphopenia, family history of immunodeficiency, family history of unexplained death, family history of failure to thrive, sibling death, recurrent infections in the sibling, we have to be careful before giving BCG. And CGD, chronic granulomatous disease, is notorious for causing BCGosis. And MSMD, I've seen one case which presented with BCG Adenitis, which turned out to be gamma interferon receptor deficiency. And infection-related conditions, like, for example, severe HIV with low CD4 count, and other T-cell disorders like DJAR syndrome. The child has got hypocalcemia, lymphopenia, and absent thymus or small thymus. You should not be giving BCG. And anaphylaxis to any vaccine component of BCG is a contraindication. Evidence for previous exposure to pathogen, previous BCG vaccine, history of TB is a relative contraindication. And in the UK, in an older child, they always do a tuberculin test, and if it is 5 millimeter or more, they don't give BCG. You must remember that all these immunodeficiencies may not be obvious. You have to have a high degree of suspicion. You have to get a good history. And what will happen if the child unfortunately has SCID? In addition to fighting the immunodeficiency, we'll be fighting BCGosis with all sorts of anti-TB drugs. The child might die of BCGosis rather than immunodeficiency. This is a very sad story of one of my patients who was given BCG, who developed BCG abscess like that. We cultured, we got BCG in the culture, had hepatosmegaly, it turned out to be SCID, underwent transplant, failure, repeat transplant, ultimate death. And the cause of death was actually BCGosis rather than immunodeficiency directly. So you must be very familiar with these contraindications. You should not be giving BCG to anybody who is pregnant. If I were to ask you, what is a neonatal BCG policy in the UK, you'll all be surprised to receive an answer. What is that answer? If I were to ask you what is the age at which BCG vaccine is given, which BCG vaccine that is given in UK, you'll be surprised it is done at 28 days. The reason is they are doing immunodeficiency screening routinely, and the screen reports come by 4th week, and only after that they give BCG. I am sure in India also, where the incidence of primary immunodeficiency is expected to be to be around 1 in 1,000 to 1 in 5,000. I am sure 10 years from now, we'll also be not giving BCG in the newborn period. We might be delaying it for routine screening, like routine screening for hypothyroidism or other conditions. We will screen for immunodeficiency and then only give BCG later. Coming to the treatment, if there is a serious effect like BCGosis, chemotherapy with 3 or 4 anti-TB drugs should be given. Many of them could be INH resistant. Pyrazinamide will not work. There are no controlled trials. Macrolides are given. Aminoglycosides are given. Surgery may be required for osteomyelitis. And of course, if there is the slightest doubt regarding the size of the BCG lymph node and abscess, you should do immunodeficiency workup. Coming to BCG in HIV children, you should give BCG. HIV exposed asymptomatic BCG can be given. Neonates with confirmed HIV, if BCG is not given at birth, delay until ART is started and the child is immunologically stable. HIV infected, those who are on retroviral therapy, if immunologically stable with good CD4 counts, should be given BCG. What about neonates born to mothers with pulmonary TB? Now there is no confusion. We give BCG, we also give INH unless it is multi-drug resistant TB in the mother. What about other vaccines which can be administered with BCG? All vaccines can be given. Previously, there was a recommendation you should not be giving measles or MMR. Now that recommendation is gone. Any vaccine can be given along with BCG. And these vaccines won't interfere with the BCG immunity, and BCG doesn't interfere with the immunity to these antigens. Coming to preterm, this is again another gray area. Many a time preterm vaccination is delayed. There is no reason why you should not be giving BCG even to a baby who is 1 kg. There is data on safety even for 1 kg, 1.5 kg. If the infant is medically stable, most of them are medically stable by the time they leave the nursery, you should give BCG. The only problem is technically it may be very difficult to administer the vaccine below 1.5 kg. Somebody very experienced should be giving this vaccine, and it's not contraindicated. Chronological age can be followed for BCG vaccine also, unless there is a medical contraindication. And active skin disease like eczema, you should avoid temporarily. Anybody who's being investigated for HIV, you should be careful. Even if IVIG is given, blood transfusion is given, there is no need to postpone BCG vaccination. Coming to the last difficult area, that is the BCG lymphadenitis. This is a very frequent, difficult problem to treat. Look at this child who had BCG adenitis like this. If I were to ask you, what is the correct treatment for this child? Straight away send to a surgeon for excision, or you give ATT with INH or INH plus rifampicin as we used to do for 6 months, or you aspirate if it is soft, or you give 2 weeks of erythromycin and cephalexin, time-tested antibiotics. The correct answer is repeated aspiration. We have moved away from excision, we have moved away from anti-tuberculous drugs. But the problem is that we should remember anybody who has BCG adenitis, any shrewd clinician should look out for immunodeficiency. Look at this paper from CMC Vellore. 40 infants they studied with BCG adenitis. 9 had disseminated disease. 15 were suspected to have immunodeficiency. 12 were proven to have immunodeficiency, such as MSMD, severe combined immunodeficiency, CGD, etc. And monoresistance was seen in BCG adenitis in 1/3. So you must be careful in giving ATT to these children. So the message is, if you have suppurative BCG adenitis, please do at least a basic workup of ruling out HIV, ruling out lymphopenia, and looking for immunodeficiency clues. Investigate. Don't allow the child to worsen. And if you want to know the correct treatment policy for BCG adenitis, if it is non-suppurative, ipsilateral to the BCG side, do nothing. Reassure, monitor the child, follow up the child on a monthly basis. And it's likely to resolve in 90% of cases. On the other hand, if it is suppurative, please send it to a surgeon, tell him not to exercise, ask him to repeatedly aspirate. And don't worry about sending the pus for TB culture. You know you are given vaccine. What is the point in sending? And if repeatedly the child requires needle aspiration and it fails, and that size is more than 2 to 2.5 centimeter, multiple attempts at aspiration don't succeed, then refer it to the surgeon finally for surgical excision. Meanwhile, work up for immunodeficiency. With this, I will conclude that the IAP ACVIP has given very nice recommendations for BCG, which includes recommendation of a single dose for all newborns, which includes recommendation to administer at the earliest opportunity if the neonatal dose is missed, right up to 5 years. And the ACVIP does not recommend mentor testing before giving BCG in an older child. The ACVIP recommends a dose of 0.1 ml above 1 month of age. The ACVIP says you should give only in the deltoid. So the messages are, in spite of all this, we must understand current BCG vaccines, where a current BCG vaccine is available, has got multiple limitations and disadvantages. But we need to continue the existing policies as of now. We may in future have to revise the schedule of timing of vaccination as in the UK in the near future. The search for an ideal TB vaccine is on. Multiple studies are going on. Bharat Biotech is conducting a trial. Several candidates are in the pipeline. Right now, we don't have any in our hands. Let us hope we soon have a perfect TB vaccine. Let us try to achieve the goal of TB eradication by at least 2030, though it looks far-fetched as of now. Thank you very much. Over to Dr. Nandini Kumar.
Thank you, sir. I think so many facts, starting from the history and then the technique, and everything has been cleared out by you. There are a few questions in the chat box. With your permission, can we just answer them, sir?
Yeah. Let me see the chat box.
So, yeah. A newborn has been given 2 doses of intravenous immunoglobulin for RH incompatibility complicating jaundice. When can you give BCG in this child? I think you said that
it's not a contraindication. Intravenous immunoglobulin is not a contraindication for BCG vaccination.
Okay.
One. The only vaccines we should not be given after intravenous immunoglobulin is for 11 months, you should not be giving MMR and chickenpox vaccine, which are live. All other vaccines can be given. BCG vaccine is not contraindicated in those who have received blood transfusion or intravenous or IVIG.
Dr. Muruganandam wants to know why BCG produces a scar when other vaccines which are given by intradermal route like polio does not cause a scar.
It causes, it's a live bacillus which causes necrosis locally. That's the reason why it produces a scar. Whereas your polio virus, which you inject into the polio vaccine that you inject, is a killed vaccine. It doesn't produce any tissue necrosis. Here, the Bacillus calmette-guerin is a live bacillus which produces tissue necrosis. Even in normal individual, you can have a scrofuloderma-like picture following BCG vaccination, even in normal individuals. Since it is a live vaccine, it produces that. That's the answer to the question.
Do we ask for a history of immunocompromised people at home before giving BCG to older children? Dr. Jayashree Ashwin wants to know.
No, you can safely give to contacts. No harm, no harm. The only problem is if there is a slightest, if there is somebody in the family who has got immunodeficiency, I will tell them not to give neonatal BCG unless immunodeficiency is ruled out. In fact, if you look at the current data on screening for immunodeficiency, you'll be surprised to know that in New York City, about 10 years back, they've started a program for screening for immunodeficiency right in the newborn period. I'm sure such a thing will happen in India in 10 or 15 years. Immunodeficiencies are quite common. In fact, I know many a case of SCID die of BCGosis, where you have to give, you have to give anti-tuberculosis therapy until the child is completely cured with a bone marrow transplant. Otherwise, you'll have to give ATT, and ATT in a child with SCID, giving drugs like, INH, rifampicin, aminoglycoside, azithromycin, moxifloxacin is highly toxic. very difficult. For these reasons, if there is a slightest doubt of anybody in the family having acquired or congenital immunodeficiency, you should not be giving neonatal BCG without ruling out immunodeficiency in the newborn. Nowadays, mid-genome exome sequencing is available, though costly. We can send the sample, get the reports within 4 to 6 weeks, then we can give BCG when we are sure we are not dealing with immunodeficiency. And in fact, now it is suggested that you should start suspecting immunodeficiency. You can't wait for the 10-point model. You should start suspecting immunodeficiency if, for any reason, right reason, an infant or a child has received IV antibiotics once. That is the way they have reduced the threshold for working up for immunodeficiency. Family history of immunodeficiency, failure to thrive, or receipt of IV antibiotics once have been the most important useful predictive factors for primary immunodeficiency. So our antenna should be up, our index of suspicion should be high, our threshold should be low for suspecting immunodeficiency. There is no harm in waiting for 1 month in giving BCG. After all, we know the baby is not going to go to the community and get itself exposed to TB so fast.
So we learned from you, sir, that just before giving neonatal BCG, stress on, take details about the family history, and whenever there's a suspect immunodeficiency, keep your antenna high and then try to exclude before giving the neonatal BCG. Dr. Ashwath wants to know, a child is given Rituximab. IAP guidelines recommends repeating the entire schedule of vaccination. Does it include BCG too? And
Yes, yes. I already mentioned that mother receiving monoclonal antibody or rituximab also, those babies also should not be given BCG at least for 6 months. 6 months. In fact, most of the guidelines recommend before giving rituximab or other drugs like tocilizumab for vasculitis or for rheumatoid arthritis, they recommend, most guidelines recommend doing HCV testing and also IGRA. Most guidelines, they recommend IGRA. In fact, wherever I have used tocilizumab or rituximab for rheumatology diseases, Dr. Satish is also there. It's recommended that you should do your IGRA test before starting all these drugs. So you have to be careful.
Dr. Ashwath wants to know, but I think you've already answered. After IVIG, is there any minimum time to start BCG? No, that already you answered, sir. No. And there are lots of praises. Dr. MSV has said, fantastic talk, great message, lots of practical points, great lecture by Dr. Pongode. Thank you so much, sir. Thank you very much.
Permission of share one question, sir. Sir, role of BCG above 60 years, sir, to induce innate immunity so that during COVID, any role, sir, anything like that, sir.
Very little data is there. Very little data. See now the Onco-BCG is used for bladder cancer. It is injected locally. And, BCG improves the immunity of any individual by improving T cell function, by improving gamma interferon levels, by improving IF and for so many other, I don't understand all these immunological reactions. It definitely improves the cell-mediated response of the individual. It also improves the immunoglobulin response to infection. But I don't think there is any international body which recommends BCG to adults. There is no recommendation, sir. And if there is anything recent, I'm honest in telling you, I have not looked at that. Since we are worried about children, I didn't look at the data with regard to adults. I don't think anybody recommends routine BCG vaccination to adults. I don't think there is any recommendation, sir.
Thank you, sir. Thank
you. Somebody wants to know, sir, like...
yeah, Onco-BCG. Yeah,
Onco-BCG is accidentally given.
Yeah.
To be done.
Onco-BCG contains a lot of bacilli, and it can cause abscess. It can cause BCGiosis. Actually, the exact treatment protocol is not known. That's my correct answer. But anecdotally, a few reports in Pakistan, they have reported higher dose of BCG being given, and many of them given ATT for 3 months or 6 months. They give ATT for 3 months or 6. That is one method. Second is, if you detect it immediately, one of the methods they say, if it is still soft, you can try to aspirate. Suppose you see, it's going to happen, and if somebody recognizes immediately, what you can do is to put a needle and try to aspirate the entire thing out. 3 to 6 months ATT is anecdotally mentioned in literature. There is no consensus on the best way to treat, but your Onco-BCG erroneous administration has not resulted in much mortality. Only 1 or 2 in Pakistan have died. And that also, we don't know whether the infants died of Onco-BCG or because of immunodeficiency. So if you detect it, immediately try to put a needle and try to aspirate. And offer the benefit of ATT for 3 months, if it has been given in high dosage.
Dr. Ashwath wants to know, many a times BCG is given in the thigh and hepatitis B vaccine in the arm. Does it work or should we revaccinate? I think it's a misplace of
no, there is giving BCG in sites other than deltoid is not contraindicated, but there is lack of data. One. Second is, we want uniformity. For example, your BCG erythema is an excellent clue for a diagnosis of Kawasaki. In fact, I can tell you, I would have diagnosed Kawasaki at least for 15 cases based on BCG erythema giving the clue before other clues appeared. So, if you have it in the site which is uniform, it will be better. So, it's better not to give in the thigh, but somebody gives, it is off-label. It's not a contraindication.
Sir, if an NRI child who's less than 5 years, if BCG was not given during the first visit to India, can it be given during the second visit to India?
Yeah, second visit, third visit, fifth visit, seventh visit, any visit you can give up to 5 years.
Okay.
In fact, now the ICMR, for want of time, I didn't touch upon 2 areas. One, the ICMR is doing a BCG revaccination trial in Mumbai slums, 14 years and above. They are doing it. And the results, I believe, are encouraging. Now, the ICMR is debating whether they should introduce BCG revaccination in adolescents and adults. There is enough African data that BCG revaccination prevents adult tuberculosis.
Thank you very much, sir, for sharing such nice thoughts and very lucid thoughts about BCG. Next,
Dr. Nandini, if you permit me.
Sir, yes, sir, please.
Oh, sorry, Dr.
Ramswamy, sir.
Excellent talk by Dr. Balasubramaniam. I just want to know, once the incidence of tuberculosis comes down to very low levels, like what has been happening in the advanced countries, do you really foresee a situation where this vaccine may be discontinued completely?
I'm not an astrologer to predict, but that's very likely to happen, sir. Because in the West, they don't give BCG vaccine at all. I would agree with you that a vaccine with so much of uncertainty regarding protection against adult tuberculosis, if the incidence comes down remarkably like in the West, yeah, we need to consider, that's a public health decision. I'm afraid as a poor clinician.
No, you're an excellent clinician. I enjoyed your talk. You don't say poor. That adjective poor is not required. An excellent talk, excellent overview. And I think your stress on, thinking about immunodeficiency is really the most important message. I think, thank you very much. Thank you.
Thank you.
Thank you, sir. Thank you, sir. Next, we would go into the second session, which will be on hepatitis B and on polio. And this will be delivered by Dr. Rajasekhar. And I request Dr. Jalil, coordinator, to introduce Dr. Rajasekhar, following which I'll be sharing the slides. Dr. Jalil to introduce Dr. Rajasekhar.
Thank you, Dr. Nandini. And now it's the time to thank the IAP TNSC for giving this wonderful platform for our IAPNs. I thank personally and Dr. Rajendran and his team to lead a very good event in this year, 2025. And thanks all the dignitaries in the platform. And my thanks goes to Dr. Balasubramaniam also, sir. Very fantastic. Thank you for our invitation and acceptance. So now I have to introduce Dr. B. Rajasekhar, who is my close friend and our own brother. And he is from Visakhapatnam, and he is my co-EB in 2021. He is a professor of senior consultant and professor in Visakhapatnam, and is an active member of IAP from 2000. He worked as secretary, vice president, and president IAP Vizag. And he is also a member of ID chapter, and he is a state chapter EB member 23 and 24. I know him personally. He is a very humble, sincere, and rising star of South India. Thank you, sir. Now I request you to take on the two topics, hepatitis B and oral polio vaccine.
Sir, are you sharing, sir?
So, madam, you will be sharing or else?
I'll share, sir. I'll
Yeah,
share
okay.
if you want.
Firstly, I express my heartfelt thanks to the team, Tamil Nadu State Chapter, for giving me this opportunity to be at this evening with all the elite pediatricians of Tamil Nadu and across India. And the most important is to be with Dr. Balasubramaniam, the doyen of academics and pediatrics. And it was a wonderful opportunity to be here and learn many, many points from Dr. Balasar in the same fantastic way of presentation. Thank you, Balasar, for making me more enlightened by your talk.
Sir, is my screen visible?
Yeah.
So we are going to take up first about hepatitis B. So we all know this hepatitis B vaccine has got different schedules. We, as per the UIP, and we give all the first dose is the 0 dose, or the early dose should be given definitely before 24 hours, followed by 6, 10, and 14 weeks. And there are also the earlier it used to be 0, 1, and 6. As there are different schedules, do you think which schedule is highly immunogenic? Is any schedule highly immunogenic, sir?
Madam, firstly, I want to tell that the basic of vaccinology. Once we know all this, then all the questions and answers, we can set it right. The most important is that, madam, when coming to the topic of vaccinology, what is the role of vaccines? The role of vaccine is to protect the child, protect the community, and protect the total world. For this, guidelines have been taken. And guidelines are taken, whenever they're taken, there should be a reference to context. So the guideline is like in the particular region, particular country, and various districts and everything. So what it is done. Let's give example of our ACVIP schedule and NIP schedule. Every time it is confusion. There was a confusion when mumps came into the schedule, that why mumps is not being in the NIP schedule. NIP schedule is taken into, all the guidelines are best. NIP schedule takes into consideration the epidemiology of the disease. IIP schedule takes the consideration of the child first. So we have to have a schedule which is highly immunogenic, highly efficacious, and it has got a good safety profile for a child as such. When it comes to the NIP schedule, epidemiology is taken into consideration, morbidity, mortality is taken into consideration, and then the cost effectivity. So coming to any schedule at that particular aspect at particular time and the reference to context, the schedules are all good. So when we take the context that, if you see the slide, you see, madam, we see that when it is given at 0 and 1 and 6, we thought it was the best schedule, but it comes to around 96 to 98%. 0, 1 and 2 months, 96%. The one we give at 0, 6 and 14s, is it inferior? No, it is 95 to 96%. The one which is given at the US, that is 2, 4 and 6 months, how much superior? It is only 99%. So all the schedules which have been written here are immunogenic, and it is having a good safety profile with the actual individual vaccines, and also they are efficacious. And this should be given along with the birth dose of your hepatitis B vaccine. So this is
So we have learned that any schedule is very good. The immunogenicity is well above 95%, ranging up to 99%. Only caveat is it should be given within 24 hours.
the first dose.
First dose should be started by 24 hours. So here is a 1.6 kilo female preterm baby who's delivered and the child is stable. And the mother is HBsAg negative. Should hepatitis B vaccine be given to this newborn neonate?
Coming to the reference to counter this question, why we are thinking of this? We know the preterm has a less, when a vaccine is given to a preterm, especially when it is less than 2 kgs or a preterm baby, lower baby, the immune response is less when it is compared to the term baby. Here, then why do we give it? Here, the consideration is taken that we are giving the birth dose to prevent the horizontal transmission. So the WHO recommends that there is a universal birth dose to all. Though the immunogenicity is less, but we have to form a programmatic purpose for a programmatic purpose, and whatever the immune response is there, then we give the birth dose. The reason is here different. It is a programmatic reason. Because we have seen that 1.3 times what happens is that the child of the preterm child response is very less. So this dose will not be counted as a part of the primary season, and further 3 doses should be administered, taken into consideration as a programmatic purpose.
So a preterm baby, even if it is, you need not wait for the weight of 2 kilos. You can give it provided the baby is stable. That's the main thing. But this dose is considered null and 3 further doses have to be administered.
And here the question was about a low risk child.
Low risk. A mother who is HBsAg negative. This is a 25-day-old newborn who did not receive the birth dose of hepatitis B. Now the parents have come to you for the first time and they brought the baby for the birth dose. What should we do? Should we give the dose or should we ask them to come by 45 days, that is 6 weeks, during the routine immunization to give the regular vaccines which contains BCG itself?
Here, someone may be having a doubt because thinking of the schedule that in case of basics, when we learn about the basic of vaccinology, when 2 doses are given, within here the span was only around 25 days and 6 weeks. Around within 20 days, if it is given, the immunogenicity response to the first primary dose will be less. But the reason why we are giving here, the giving a dose of hepatitis B, that is less than 7 days, it has been seen that the carrier rate has been decreased from 6.5 to around 3%, 1%. When it is given after 7 days, which is called as the late birth dose, the carrier rate decreases from 6.5 to 3.5%. Still, there is an added advantage. So, the WHO recommends that all infants receive the late birth dose during the first contact with healthcare providers at any time, up to the time to the next dose of primary schedule. The birth dose should be given after 24 hours, should be reported as a late birth dose, but timely birth dose importance for curtailing the perinatal transmission. So here also is a programmatic purpose.
So we know that the timely birth dose is as soon as the baby is born and definitely before 24 hours. However, any dose after 24 hours is considered as a late birth dose.
But it should be given.
Yes, but it should be given. Can a hepatitis B vaccine be given to an immunocompromised child, sir?
The question has come because we know that live viral vaccines are not contraindicated in the immunocompromised child, but it is a bacterial vaccine. So it is an attenuated bacterial vaccine given an immunocompromised child, the immunogenicity is less. Think of the disease. The disease is more dangerous because when there is a chronic carrier state, they go into cirrhosis and liver cancer. So we have to prevent that one. By giving hepatitis B vaccine, though the immunogenicity is less, we say that it should be given. Then what is the strategy for giving? Number of doses. Is the same dose given? No. Double the dose is recommended for that age. And then what should be done in an immunocompromised child when hepatitis B vaccine is given? I have given a double the dose. Should I check the antibody test? Yes, we do an antibody test because we want to know the antibody status in this child. Then can we give any other schedule than 016? Yes, I need the antibody response to be fast and it should be prolonged. So the vaccine can be given as accelerated schedule of 1 to 12 months can be used in this case.
And if somebody is not responding even after 2 doses, probably consider immunoglobulins.
Immunoglobulins as we go for the post-exposure prophylaxis schedule.
So we have a standard dose, as sir has already said, it is 10 micrograms or 0.5 ml, whereas under 18 years of age, whereas above 18, it is about 1 ml, which is 20 micrograms. So here we'll be using a double dose, which is 1 ml.
Yes.
So Virat is a 6 months and an 18 days old infant who comes. His mother is hepatitis B positive. So because of this, Virat received hepatitis B vaccine as well as he was given the hepatitis B immunoglobulin at birth. Is it necessary for us to test the infant's blood for antibodies to hepatitis B surface antigen? That is IgG anti-HBs AG. If it is to be done, if it is yes, sir, when do we do the test?
Why do you want to do a test? It's a high-risk child. So in any high-risk child, we should do a hepatitis B surface antigen test and anti-HBs antigen. Then comes the question when it should be done. The test for HBs antigen and anti-HBs should be done at the age of 9 to 12 months or 1 to 2 months after the final dose of the vaccine series if completion of the series is detailed. Why after 1 to 2 months? After 1 to 2 months, suppose we complete the series 0, 1 and 6. Can I do at 8 months? No, I cannot do. Because here one thing is there that in this scenario, what happens is that suppose I do 1 to 2 months after that's around 7 or 8 months, the HBs antigen will be negative. That's well and good. But what happens to the anti-HBs antigen? We have given the hepatitis B immunoglobulin at birth. The anti-HBs which is there in the body of the child persists for around 9 to 9 months minimum. So if I do the anti-HBs antigen at 7 months, then this will come as a false positive. So in this scenario, we do the HBs antigen and anti-HBs antigen test at the age of 9 to 12. The reason in this.
So sir has made it clear that anti-HBs antibody, you should wait and do only by 9 to 12 months because the hepatitis B immunoglobulin that you're given at birth for immediate passive immunization of the newborn can give false positive. So please wait and do the test only by 9 to 12 months. So after giving hepatitis B to healthy children, should we routinely use hepatitis B vaccines, but we don't test the anti-hepatitis B antibodies as such? Is there any role of the antibody testing? And is there any other indications? We had one indication, which is the hepatitis B infant who's born to a hepatitis B positive mother. So are there any other indications for antibody testing after hepatitis B vaccination other than babies who are born to hepatitis B positive mothers?
So as it said, any healthy person, immunocompetent person they is not recommended to do anti-HBs testing. But in case of high-risk children, other than example which we have already given, we have to take this anti-HBs testing for hemodialysis patients, people with HIV infections, other immunocompromised patients, people at occupational risk of exposure, needle stick injury, sexual partners of HBs antigen positive people, because the antibody titers are important in these cases.
Sir, if you want to do the test and then vaccinate your patient for hepatitis B on the same day, which should be done? Does it matter if we test or vaccinate first? Which should be done? Should we do the test, the blood, and then vaccinate? Or you can vaccinate and then take the blood for test?
So what happens here in this situation is that the personnel who has been exposed to a needle stick injury, I have got either the vaccine, I should give the vaccine and test, or should I take the blood and test? the blood is drawn first and then administer the first dose of vaccine, because if the vaccine is given to that particular person, there may be transient HBs positivity. So this will again show a false positivity in the blood, and it will hamper our treatment protocol.
Like Sir had said that the hepatitis B immunoglobulin, which we given to the newborn for passive immunization, persists, and don't please always wait for 9 months and then do the test like that. Whenever you give the vaccine, though this is a recombinant, it is a hepatitis B surface antigen. So when you give a vaccine, a small percentage of individuals can have a transient hepatitis B surface antigenemia, and that can make it false positive. So if you give the vaccine and maybe a few days later when you do the test, then you will put the person as if the blood was infected or probably is a pre-existing carrier or something like that. So always draw the blood and then give the first dose of the vaccine, as we have a transient hepatitis B surface antigen positivity in these individuals. How long should a person, sir, wait to donate a blood or have an hepatitis B surface antigen blood test after a dose of hepatitis B vaccine?
So what happens, same theory here also. We should know that after someone gives a blood transfusion, he should not go, after he takes a blood transfusion, he should not go for a blood transfusion after giving a vaccine, because this vaccine transient HBs positivity can be detected up to 18 days after hepatitis B vaccination. Suppose in an immunocompromised patient, it is detected up to 50 days. So the average rule is that it is advisable to wait at least 4 weeks after giving hepatitis. One has taken hepatitis B vaccine, and after 4 weeks, he can go for the blood transfusion.
Yeah. If this is not kept in mind, a person after taking hepatitis B vaccine wants to really donate blood, and then his blood is tested, and then it is hepatitis B surface antigen positive, he will have a hell of a problem because he thinks he got the disease, but this could be only due to a transient antigen from the vaccine. So you should always wait for 30 days before donating blood or going for testing. Sir, Anjali is a 22-year-old lady. Her husband was recently diagnosed to be hepatitis B carrier. She was given 0.5 ml of hepatitis B vaccine. This was noted when she came after 1 month for the second dose. Is this dose valid or invalid?
So here, what is the crux in it? Anjali is 22 years old, so she should receive 20 micrograms of the vaccine. Then here she has received only 0.5, that is 10 microgram. So it is an invalid dose. Then once it has been invalid dose, what can be done? Suppose the error was discovered while the person is still in the office, we can administer the other half the hepatitis B vaccine dose. Suppose the error is discovered later, as we told, it was an invalid dose because it was a 0.5 ml, that's a 10 microgram. So the person should be given full age appropriate 1 ml repeat dose.
So in the case of Anjali, this 0.5 ml is null or an invalid dose. Therefore, we should start her with a full dose of 1 ml.
So from there, it is 0, 1 and 6.
6.
Or whatever you 0, 1, 2, 12 or whatever.
Okay. Dr. Vatsalya, she's a 20-year-old female. She took 3 doses of hepatitis B as per schedule, 0, 1 and 6. And as she is a doctor and a healthcare personnel with a high risk for contracting the diseases, she wanted to know, and therefore she tested 6 months. After 6 months of completion of the last dose, she went and checked her antibody titers, that is anti-HBs, and it was found to be only 5 micro international units per ml. Is she a non-responder, sir? Can you explain?
So basically, or whatever, sometimes what we think is that after giving one series of the vaccine of 0, 1, 6 months, and there is no response, because the response should be 10 milli international per ml, some may label as non-responder. But the definition says that person who does not develop protective surface antibodies after completing 2 full series of hepatitis B vaccine. So here she has taken only 1 full series, so she cannot be labeled. Is it only that much? No, there is an addition to it. And also, that person should be excluded from having an acute or chronic hepatitis B infection, has to be ruled out in these persons, because if there is HBs antigen positive in a chronic infection, you cannot call it as a non-responder. So these two criteria has to be fulfilled to label a person as a non-responder.
So this doctor had just completed only one course.
One.
So with this, we cannot call her as a non-responder until another course has been given, and then only later. And we'll have to exclude also, as sir said, chronic hepatitis B infection.
So the CDC recommendations for hepatitis B non-responder is that second vaccine series has to be given, or the Dr. Anjali has to be evaluated to determine if she is SBS positive, whether it is acute or chronic infection. And the latest recommendation by CDC at 2013 was that for a second series, a different brand of vaccine should be administered. Why a different brand? If the question arises here, then now in US and there is a European Union, they have got a new vaccine, recombinant vaccine with a strong CGP adjuvant, that is Heplisav. This vaccine has got a high immunogenic response. So they have told that this vaccine can be given to this the persons who have not responded, and the dose for that vaccine Efficacy is 0 and 1 month. Only 2 doses at interval of 1 month. The other thing is that suppose how many cases of non-responder are that? It is usually 5 to 15% are non-responders. And any effect by giving a second dose of vaccine to this why should we give a second dose of vaccine? In non-responders, if we are given a second series of vaccine, it is seen that 30 to 50% respond to this second series. So the second series is advocated.
Suppose a person is a non-responder, that is not responding to even 2 full series of vaccine and retested. Such an individual has to take hepatitis B immunoglobulin during any high-risk situation. So thank you, sir. And I think I hand over the forum to Dr. Jalil to proceed with the next topic, that is polio.
Thank you, Dr. Nandini. And we'll move on to the next vaccine, the polio vaccine. You know, there is a fallen cases of, say, about 99.9 since 1998. India, you all know, declared polio-free in 2014. Still, there is a re-emergence of this polio in the neighboring country. Now, we will move on to the next topic, that is polio vaccine. I request Professor Rajasekhar sir about the types of polio vaccines and the common schedule.
Yeah, normally, we know that what are the vaccines, polio vaccines available. The oral polio vaccine as well as the injectable polio vaccines are available now and in the market. The trivalent OPV has been out of use from last 2016. So the present is the bivalent OPV, what we are using, then monovalent OPV type 2, which we are using during outbreaks. The new vaccine that has been novel vaccine, that is the NOPV. We'll go through the NOPV in our discussions. The IPV vaccine, injectable polio vaccine, has come into the market. We know the good, what the better part of it. And the new vaccine that have been available in around 43 countries for last till March 2024 is the Sabin IPV from the Sabin strain. So coming to the schedule, as I was discussing earlier when I was talking of the basics of vaccinology, which schedule? Is ACVIP schedule better or NIPI schedule? At its own place, all the schedules are good. And now the question arises more because we are getting more patients, more and more patients are going for the NIP schedule and then coming up to us. And should we give this vaccine, especially coming to the pneumococcal vaccine, as well as our polio vaccine? So therefore, what is happening is that there are some questions which have arisen. We'll go through the discussions. In ACVIP schedule, as I told, it should be highly efficacious, immunogenicity, and it should be very safe. So to make the schedule highly immunogenic, 0.5 ml IM IPV at 6, 10, and 14 weeks is given, booster at 18 months, and then at 4 to 6 years. But 0 dose OPV is still to be continued, knowing the added advantage of it. Coming to an NIPV schedule, OPV 0 dose, advantage is well known, plus oral OPV at 6 weeks, 10 weeks, and 14 weeks, and 18 months, along with FIPV ID doses of IPV at 6 weeks, 14 weeks, and 9 weeks. This is the schedule that is taken. Coming, if someone asks whether pulse polio immunization is approved by both ACVIP and IP and the NIP, yes, it is given approved by all the children below 5 years, both by the ACVIP and IP. So this should not be disturbed when someone asks that there is a pulse polio program going, we get a phone calls, we should always advocate that yes, it should be taken.
Yes, sir. Having thought of these types and the schedule, are there any drawbacks of oral polio vaccine, sir?
Yeah, we are seeing the drawbacks now. We saw the advantages earlier. Now the drawbacks are basically two major drawbacks. That is VAP, and that is a vaccine-associated paralytic poliomyelitis and vaccine-derived poliomyelitis. The advantages were good because it's always a risk and benefit ratio. We used the OPV for various benefits that was already taken into consideration. Now, because the side effects, whatever is telling, what are the drawbacks is coming up. So the discussion here is that how many cases of VAP occurs? 1 in 2.7 million doses of OPV given, then VAP occurs. What happens? What the OPV which you are giving is a live attenuated virus. If it is a live attenuated virus, why it is changing into neurovirulence? So this virus in some of the children, what happens when they multiply, they attain the neurovirulence. But is it a risk to the community? No. This VAP associated virus is not a risk to the community because they are not transmissible. The second is vaccine-derived poliovirus. What is the difference here? In the case of vaccine-derived poliovirus, what happens is that when the OPV which someone has taken, then what is there is that they interact with other enterovirus which is present in the body, and there is a genetic variability of around 1 to 15% in the VP protein 1. So they revert back to neurovirulence, and additional problem is that they have a power of circulating in the environment. So they are very dangerous because it is transmitting in the society and it will again cause the polio disease. So are there any other differences of CDPV? Yes. There are 3 types of vaccine-derived poliovirus. That is the circulating in the environment, and the other one is the immune-associated vaccine-derived poliovirus and the ambiguous vaccine-derived poliovirus. Those which are circulating is known as the circulating VDPVs, and where it is seen wherever there is inadequate OPV coverage, and the virus which has been isolated from persons with immunodeficiencies are known as immunodeficient associated VDPs. The problem is that when OPV is given to these children, what happens is that they multiply and they excrete in the community for about more than 20 years. That's the most dangerous part of it. What is an ambiguous vaccine-derived poliovirus? The vaccine-derived poliovirus which has been mutated and it is transmissible. If they have been derived from persons with no immunodeficiency, or when they are isolating in an environment which is not, where there is no source delineated, then it is known as ambiguous vaccine-derived poliovirus.
So we all heard about that two major disadvantages. Sir, what is an ideal IPV schedule, sir? After we have only at birth we are giving OPV, followed by the IPV. What is an ideal IPV schedule?
If you talk about the ideal IPV schedule, then someone may ask that is NIP schedule not ideal and is IIP schedule ideal? Reference to context, both are ideal. Then coming to the context of our IIP schedule, the studies were done with 2+1, 3+1, 3+1+1. This 3+1+1 is an ideal if a child is taken into consideration, individual child is taken into consideration. The titers which were given, which develop after 3+1+1 is very high. And this high titers is very important when we discuss about the child, individual child. What happens is that we know that IPV also has a gut immunity. How it is that? If I give a 3+1+1 child, that is what primary we give IPV at 6, 10, and 14 weeks in our clinical practice, we give at 18 months. If this schedule is given, what happens is that they have got a high antibody titer. This antibody, IgG antibody, when it is very high, it percolates into the gut, and it also helps in gut immunity. So when there is a gut immunity by the IPV, what this helps in replicating of the virus in the gut is one of the help, and the other, the transmissibility is decreased. So by this 3+1+1 schedule, we get this response. Suppose someone tells that 2+1 schedule, which is given in the government, 6, 10, and 6 weeks, then 14 weeks, and the 9-month schedule. Is it immunogenic? Yes, it is immunogenic. The seroprotection level is good. Then, but the titers are not that high in these children. But for a community purpose, we can accept 2+1 schedule. For a child, individual child, which in our clinical practice, we'll go for the 3+1+1 schedule.
Yes, sir. So we heard about the type 1, 2, 3 types of polio viruses. The type 2 has been removed, and you have a monovalent, bivalent. Now we heard that is NOPV, that is a novel OPV, and SIPV, that is a Sabin IPV. What is it, sir?
Why a novel OPV has been developed? The reason is that now we have MOP, we have got the cases of VDPV, all these vaccine-derived poliovirus transmissibility is there. We have gotten outbreaks because of the poliovirus type 2. When we are giving again in a community of MOPV2, there is a risk that this vaccine may mutate, and there may be neurovirulence, and again there will be this problems of MOPV. To curtail this, the novel OPV strain of serotype has been developed. This is a genetically modified version of the Sabin strain of poliovirus 2. This advantage of this genetically modified strain is that it will cause what the vaccine-associated poliomyelitis, neurovirulence, and transmissibility is less. So this has been developed. This has been used in 18 of the 21 countries. It has been used, but some studies have shown that in Democratic Republic of Congo and Burundi have shown few cases of CDPV linked to NOPV. But taking these two countries into consideration of some of the side effects, still it is considered NOPV as a good vaccine for an outbreak situation. But it is not used in a day-to-day practice. It is only used for an outbreak situation.
Next slide.
Coming to the Sabin IPV, we are using the injectable polio vaccine is the killed one, the SARS strain. What are the advantage of Sabin? When you take an IPV from the Sabin strain of polio, what are the advantage? The advantage is that it has got a good biosafety levels, so the production is easy, and the huge quantity of IPV can be produced with this. Therefore, it is one of the best advantage because IPV is getting shortage, and this IPV, once it comes into the market, it will be good, and it has been started in few countries like China and Japan. And immunogenicity is also well approved.
We'll move on to a case scenario, sir. Mrs. Harini, mother of 9 months, 16 days old baby, Ria has come for advice regarding vaccination of polio vaccine. She wants to shift to IAP schedule. He has received 6 weeks, 14 weeks, and 9 months of fractional IPV at the primary center. Is there any need for additional IM IPV recommended, sir?
So this child has received 6 weeks, 14 weeks, and 9 months. That is the 2+1 schedule. What we need is a seroprotection. Studies have shown that there is a good seroprotection. So the child is protected. Then the 9-month schedule is taken as a booster. So this antibody level continues into the 2nd and 3rd year and 4th year. Any additional IM IPV recommended? Yes. Additional IM IPV is recommended as a booster dose in 4 to 6 years because the protective level, the seroprotection, whatever is the antibody titer, decreases slowly at the age of 4 to 6 years. So this child, because she has come to us for going into the IAP schedule, so we need not give this vaccine at 18 months. This is the 9 months is already a booster, knowing the theory that by 4th year, the antibody level decreases. So we have to alert this mother that at 4th to 5th year, she has to come to take the IPV booster. So it's only, the study has shown that we have given a 2-dose schedule of IPV at 14 weeks and 36 weeks, resultant in seroconversion rate of 96, 98, and 85% for serotype 1, 2, and 3 respectively. By intradermal route, if you are giving an IM route, 99, 99, 97. So hardly there is a marginal benefit from additional dose of IM. And for infants who receive a 3-dose FIP as per NIP, any additional dose of IMIP is not recommended in the further 18 months. They have to be given a booster dose at 4 to 6 years. That's the final conclusion.
So, thank you, sir, for your excellent presentation. And
Bala sir, it
any
not be excellent,
questions in
sir.
the
Bala
chat
sir
box?
is the most excellent person to present us and learn from him.
There is one question. Child with fractionated IPV given at 6 weeks and 14 weeks come at 9 months for IPV, but as it is rarely available in private, can we give IM IPV as a combination later at 18 months?
Now, already they have taken 6 weeks, 14 weeks, and 9 months.
Yes, sir.
Then, as I explained, the antibody titer is there. The child is having a seroprotection, so the child will not get an polio. So when the child is protected with 2+1 schedule, we will not give a booster dose at 18 months. Antibody level decreases at 4 to 6 years, so we give a booster dose at 4 to 6 years.
Does it affect
Question
protection?
is different, sir, actually. The question is about 9, they come for the 9th month, sir, actually.
Yeah. Acha, they come for the 9 months because
Yes.
fractional dose of IPV is out of the label. We have to give in our clinic setup. Better is we send them back and give the fractional dose at the PSC level.
Yes.
But he has to take that, because if you don't give it 9 months, what will happen is that the antibody protection will not go into the 2nd and 3rd year of life. But if you can give an IM IPV there, because you don't, if the like this doctor, the mother Anjali didn't want, if she she has not taken the 9-month vaccine and she doesn't want to go back to the PSC, you can give an IM IPV. That's not.
There is another question, sir. Maximum age of IPV in children.
Yeah, the other I can. If you are wanting that it is not available with us, yes, one, it is not available with us. The second is that you can send to the PSC, they are giving it. If still they don't want to go, as per the recommendation, any extra dose of vaccines like Pentaxim or anything, if you want to give, but it will be out of the label. But today what we are doing is that we are sending the patient back to the primary health center to take it there.
Dr. Nadini, is there any other questions?
Yeah, somebody
Yeah,
has asked in the chat, I think, last question, just a moment.
So college students come for hepatitis B
Yeah,
vaccine. They
hepatitis
don't
B,
have
yeah.
immunization record. Shall they do vaccination without doing antibody titer? Yeah, now we are facing a lot of these issues. The best is that the recommendation by any CDC is that, or SCID is that, if you don't have a vaccination record, you don't take it as a valid dose. You have to give a vaccine. Suppose you want to do an antibody titer and give if the antibody titer is less than if he has, because here comes the question whether they tell us that they have given. We don't have a record. Then we should not write in the vaccination chart that as per the parents' verbal, as per their parents' verbal advice that yes, they have taken the record, we should not write it. Any documentation has to be taken into consideration. If you still want, you can go for the antibody titer. If the antibody titer is less than 10 milli-international units per ml, you can go for the vaccine.
Dr. M.S. Vishwanathan has asked, in health professional after completion of 3 doses, when would you give booster? Is it every 5 years, or do we need to check antibody before we have a booster?
So the booster dose, we know that there's a criteria that for any high-risk patients, and we, the healthcare professionals, are on the high-risk groups, we have to do our antibody titer. If the antibody titer is less than 10 mil international units per ml, then only we have to take the vaccine. And without doing that, we don't go for a booster. And the previous last 10 years back, we had a recommendation that we give booster dose was given after 5 years. Presently, no booster dose has been given. Only after the primary dose of whatever 6, 10, and 14 or 016, the antibody titers have been seen to be on the higher levels for around 20 to 30 years.
So
So
there is
Dr. Balaji has asked, Balaji.
unvaccinated child come at 6 years. How to give IPV catch-up, sir?
Usually, IPV, the guidelines suggest that age-appropriate vaccinations. So age-appropriate vaccination, there are no guidelines that after they come at 5 years, we give the IPV, because IPV is given only from 4 to 6 years.
So in that case, can we use the DTAP IPV combination, which is the tetra combination, though it is what we use for the second booster, because up to 7 years we can use the
Yeah,
DTAP.
madam, usually what happens is that the catch-up vaccination for IPV, usually after 5 years, we don't give a we were going to give polio vaccine. But here, if they have come at 6 years, then you can give the vaccine which is available in the quadrivalent vaccine, the IPV, and what we are having, the DTaP. We can give it.
So somebody wants to know, Dr. Balaji wants to know that the hepatitis B immunoglobulin, the adult dose recommended is 0.06 ml per kg. What is the maximum dose, especially if the person who's the adult is an overweight adult? And any specific site also he wants to know.
Site is
Intramuscular.
intramuscular. Yeah, site is intramuscular, but the maximum dose, I don't remember of that, hepatitis B, immunoglobulin.
Okay. Dr. Chalil, anything?
There is one question from Dr. Sudhakar. If a child has taken 2 doses of IPV but missed the 3rd dose, can be given 1 dose of IPV after 2 months from the last fractionated IPV, sir? Is there any?
Miss the 3rd dose means normally the question was earlier what we used to take was 6 weeks and 14 weeks if they have taken, and they come after 9 months. Scenario is after 9 months or before 9 months?
No, sir, I didn't put as a question, sir. Actually, try to answer that actually. Just putting that if they miss the 3rd dose of FIPV and come later as a catch-up like vaccination, one person has asked whether we have to wait for 18 months and give the IPV. I put it, we can wait for 8 weeks and give the IPV.
But IPV is not available.
Is it okay, sir?
Not available. Standalone is not available.
Not available.
Standalone. No, the thing is, if the standalone vaccine was available, suppose we have given at 6 weeks and 10 weeks, 6 weeks and 14 weeks, we have to give a booster dose. If it comes after 9 months or 10 months, then we can give the IPV vaccine.
And
but
that
now
was the question. I
standalone
tried to answer that question, sir.
Yeah, we can give the IPV.
Yeah.
That's
So,
what I was telling you.
Nandini,
Yes.
since there is no further question,
Any no further
to you for
questions?
the conclusion.
Thank you, sir. Thank you very much, sir.
Thank you,
ma'am.
Yeah, thanks. I hand over the thing to Dr. Tirumurugan.
Thank you, sir. Any closing comments from our president, Dr. Before that, Dr. Singaravelu, sir, any comments, sir?
Thank you, Thiru. Really, it was a very wonderful session, very, very practical, because though we are doing routine session, still a lot of debates on the SBS. He has very clearly made it about BCG, and Rajasekhar also was clear about both the OTV and Hepatitis B. It was really wonderful session. Only thing, there was no space, and many of us joined in YouTube. So definitely it reached more than 200, 300 people. So really, it's a great evening, great session. Thank you, Thiru.
I think the maximum dose will be around 5 ml.
5 ml.
Yeah, 5 ml. Yeah.
Thank you, sir. Thank you.
Thank you.
Yeah, thank you, sir.
Thank
And
you, sir.
Yeah, thank you. And really wonderful session. And I think stalwarts, Dr. SBS, he actually hit a century. Actually, today, 100 actually out of 100, no, they're occupied, and now our delegates joined the YouTube. So really happy. And I think I thank Dr. Rajasekhar also. And it's a wonderful session. And thank each and every one of you for this thing. And I want to do one of the important announcement for improve that vaccination among that public. No, that's we need IAP TNC is going to take important step. One is we are going to release that IAP TNC vaccination card like that. So some of the vaccines we are not getting from government. The way that many parents may think that all the vaccines they are getting in government setup, I think we have to make awareness among the public. That's one thing. So for that purpose, we are going to give a vaccination card. Second one is for improving our standard. Another thing is awareness and that the vaccination coverage. We are going to issue a IAP TNC certified vaccine center like that. We need, we are going to form a guideline, and from that, based upon that, we are going to issue that life members will get applying properly. We are already formulating guidelines. We are going to issue IAP TNC certified vaccine centers like that certificate where we are going to issue. We are planning that aspect. And thank you very much, sir. Thank you.
Sir, one question that Dr. Vishwanath sir, you had asked about the normally in immunocompromised, we give double the dose 0, 1, and 6. Suppose is a if the titers has not developed, you wanted that. What are the dose when you are giving the second series?
Correct. Yes.
Yes, the second series also the same double, sir.
So thank you, sir. Actually, I can just say that on YouTube we have had about 430 unique persons watching. So that's about 530 for this program.
Great.
Yes, sir. 430. So that is very huge number. So thank you very much to our convener, Dr. Nandini Madam, coordinator, Dr. Jalil, and of course our experts actually who has made it one of the most successful programs I have seen for a long time from IAP TNSC. So Dr. SBS sir and Dr. Somasekhar sir, thank you very much. We all had a great session, learning session. Of course, we'll have another one in the next session will be in March on ice. But next weekend we have got another blockbuster coming, which is for mainly targeted the P4 program, targeted for primary care pediatricians. So hope to see all of you there. Thank you very much and have a great evening. Thank you. Good night.
Thank you all.
Thank you very much. And,
Thank you, Rajasekhar sir, SBS sir. Thank you, sir.
Jalil
Thank you,
sir.
Rajasekhar sir and
much,
SBS.
Rajendran.
Thank you.
Jalil and Nandini, special applause. Thank you.
Sir. Thank you, sir. Thank you, sir.
Thank you, everyone, sir. Especially
Thank you, sir.
Bala sir.
Thank you, Rajasekhar sir. Thank you.
No. Thank you very much, sir. Thank you, everyone. Thank you, all the elite pediatricians.
Hi, Rajasekhar sir. Bye-bye.
Thank you. Bye, sir. Bye, sir. Bye, sir.
Thank you, everyone.
Bye, sir.